And I think that what brings us nicely into speaking with Claire next. So Claire works first line with patients. Claire understands the importance of compression, and Claire, it'd be really interesting to find out from you what the challenges are. Why do you feel that patients aren't being in compression, or are they not wearing it, or what's going on out there?
Katie. So, a lot of it, obviously, leading on from what Professor Rabe was saying. I work in the community. I have a team of nurses and associate practitioners under me that I work alongside. We go out and visit housebound patients for a multitude of different reasons. A lot of the patients we see have leg wounds, chronic edema, whether that's due to venous ulcers, whether that's complications of heart failure, again, all of the things that Professor Rabe was talking about. One of the biggest factors that I find is difficult with dealing with these long-term conditions is that because we only see housebound patients, we often don't see them until the diseases are far advanced, which means that we're not getting that early intervention to be able to give that correct education to these patients. So, of course, when we see them, quite often they do have reduced mobility. They're often, they're not able to get into their bed. They're not able to elevate their legs properly. They haven't had the right advice from the beginning. So they're not aware of the things that they need to do to be able to slow that disease progression or to manage it over time. Of course, in the community, we unfortunately don't go and see people for prevention. We would have someone referred into us once they have maybe a wound on their leg, if their legs are leaking. And of course, we know that by this time, the disease has already progressed to that point where we need to get that intervention into place quickly to prevent those hospital admissions. So depending on who we have going out to see the patient, sometimes that clinician may not have as much experience in lower limb assessments. So that can put a delay on the treatment being put into place the first, from that first visit. What I find is that often these patients then become resistant to having the right treatment put in place, especially if they come in with a wound on their lower leg. Someone might go in, might put a sticky dressing on it, might put a light bandage on there. But when we then go in, when a registered nurse or a specialist goes in sometime down the line and say, you've got this edema, this is what we need to do to heal it, even if we give that education, sometimes they are resistant to having that treatment in place. I previously worked in a clinic along with Katie, actually, and one of the things that we used to do was we used to have a prolonged time for that first assessment, and we used to give a lot of education, taking it right back to basics from that very first point of contact. We used to explain about the physiology, what was going on in the body, what would happen if we didn't put a treatment plan in place, and how we could improve their lives with putting that plan in place, and what we needed from them as well, because we would say to people, we can give you the tools, but ultimately you are the ones that need to put these things into action, to take ownership of your own health conditions. And what we found is those people that were getting all of that education and that intervention at that very first assessment had a much higher success rate of wound healing, of managing their conditions and being discharged and not having these recurring conditions again. Unfortunately, now working in the community, I don't have that luxury of a lot of my patients being able to put the same things in place. And often it's that difficulty as well of finding a treatment plan that works for those patients with regards to all of the different compression garments and things that are available to us. Katie, did you want me to touch on any specific areas at all?
So just being in the community and from, in the UK, we have the NHS system. So, the patients that we're seeing are getting healthcare. But what challenges does that pose for the UK? So about getting, are you able to go and see someone with wet leaking legs and change bandages 3 times a week? Is that a possibility? Is that a reality? Because that's what the patient needs. Are they able to get that? And are there any things that you do to get around giving them the best evidence-based practice? What are the challenges in nursing in the UK?
Oh, yeah, absolutely. So, often if we see people with like I've mentioned before, we see people when their disease has progressed, to that point where they're needing a lot of intervention, because we don't see them with regards to the prevention. We may see people with high levels of lymphorrhea, high levels of edema. They may have legs that are very misshapen, and we need to remodel those legs almost to be able to even get them into compression garments sometimes. Because of the way the NHS is in the UK, and because of the other things we see in the community and other almost health epidemics such as diabetes, for example, that does take away a lot of the I'm trying to think of the word now. A lot of
It's your capacity, your workload.
Yes, absolutely.
Is too high for your volume of patients. Is that?
Yes. Yeah, of course, when it comes to things like diabetes and medications that need to be given, unfortunately, these things do take precedent over wounds and over legs. We know that there is a high risk of cellulitis with chronic edemas. We know that wounds can lead to infection, but when you put that on a risk factor and a scale, it still does fall lower than certain other things. So we see palliative patients, we see a lot of people on insulin, and especially when you take staff sickness into that as well, your wounds in your legs, your chronic edemas, unfortunately, are going to be those things that are reduced down to maybe once a week, twice a week, even if the need is higher. So, of course, then that leads to us not being able to give more education to the patients. They start to maybe lose faith in the system. Their mood becomes lower with what they're going through. And then, of course, they don't want to take responsibility even more for what's going on, because they feel sometimes alone and that no one's helping them with regards to their long-term conditions.
It's a real knock-on effect, doesn't it? That these patients, like with legs, if they've got wet, leaky legs or ulcers, they then don't want to leave the house. And that's been shown in many studies. They then become isolated. They then may put on weight. And as Professor Rabe was saying, there's that increased chronic edema with weight gain. So it's a vicious cycle for these patients. So what would you, if there was like a solution, like with all of your patients, what would you, what could you do? Like, how can they help themselves? What education did you give to them? What can they do? Is it like skincare, exercise, compression, washing their legs? What does exudate do to people's legs?
I think ultimately that one of the best solutions would be to take it right back to primary care prevention. If GP surgeries had more education and could give more education to people right from the onset, when someone goes into an appointment, maybe they notice that someone's got edema, they give them the education right then. Everything you mentioned about exercise, how we can help to increase the calf muscle pump through the leg, how we can help with that flow of the fluid in the blood back up into the central circulation. We know that mobility has a big impact in that. I mean, I'm sure all of us, even if we don't have chronic edema conditions, we notice the effect on our bodies of holding extra fluid if we're not moving day to day. Skincare, absolutely. We know that if someone's got dry, scaly skin, if they've got hyperkeratosis, bacteria and infection is going to harbour, it's going to sit in those areas. If they've got skin folds, that's all going to cause breakdown of that skin. And when that skin starts to leak, if they get lymphorrhea from this exudate, it's it has got that acidic element to it. It is going to burn, sting, it's going to break the skin down further. And of course, it's going to cause more pain and exacerbate any conditions that they already have.
Yeah, absolutely. That's so important, isn't it? And we know as healthcare professionals, and it's all written in our guidelines about prevention. In the UK, we have the NHS long-term plan, which was written 10 years ago now, which has been spoken about prevention. And you know, when they release the new NHS long-term plan, I believe prevention is also going to be highlighted in that too. So there is definitely a gap there. And when we speak to Julia, we find out about what's happened. So Julia isn't a housebound patient. So she is presented to primary care, first of all. And she's been in lots of different healthcare settings. But in the UK, I think community nurses really do have a good understanding of compression, the venous system, chronic edema, and the advanced stages of chronic edema, lymphedema are treated within the community.
Yeah.
Like you say, you're seeing these patients with all of the skin changes. So where they've had some sort of venous insufficiency or lymphatic insufficiency, they've not been given a light compression garment years and years ago, and their leg has changed inside the leg. And they don't know that, do they? They don't know. So
no, and because they don't. Sorry, Katie. I was just going to say, because they don't understand, they don't want to carry on with that treatment long term. So, of course, we may heal the wounds, we may use compression therapy, whether that's bandages, stockings, wraps, or a mixture of compression therapies to be able to heal those wounds, get that skin integrity back where it needs to be, move that fluid. But once that wound is healed, because of the way the NHS is, we deal with the acute issue at the time in the community. We can no longer go in to see people to assist with applying their compression garments long term. And often if they haven't been given that proper education and they don't fully understand, that's where we then hit more of a wall, because these patients don't continue with that skincare, with that, increased mobility, with those compression garments. And of course, their wounds then recur and they end up, it's a vicious cycle. And then everything breaks down and we're almost back to square one again.
So that education with the patient, I think, is really key here, isn't it?
Absolutely.
Whenever you go and see a patient, that we're discussing that lymphorrhea, swelling, leg ulcers, skin changes, they're all just a symptom of what is happening inside of the leg. And if they know that, they're more likely to continue to wear compression or go back to services and ask for more compression, because it doesn't last forever, does it? Like a compression garment, when you've discharged the patient, it lasts 6 to 12 months. So,
and often those GPs won't prescribe further until if the person has got strong compression, they'll need another Doppler. If the patient is housebound, can't get to the surgery, so the surgery can't do a Doppler assessment. And of course, then the community nurses often are, depending on the area that they're in, often won't have the funding to go out and do Dopplers on these, what they call well legs. So again, that's another area of difficulty, because we're then seeing the same patients breaking down. Even if these patients, often they will be empowered, they will be passionate about keeping their legs healed, but it's where the system then fails them, because if they're not getting that Doppler, if the GP won't prescribe that strong compression without a further assessment, then where else do they go?
It certainly needs to be looked at, doesn't it? I think we've actually got a question, Claire. So I'm not sure how you feel about answering this, or it can be directed to Professor Rabe. I think Professor Rabe may have had to leave us, but we will certainly get this answered. So the question is, hi, good day. Usually for leg edemas, would you recommend above knee or below knee compression socks with patients with heart? Will patients with heart failure develop any pulmonary edema in compression socks is advocated? So I think we may have two questions there. So for leg edema, would you recommend above or below knee? Claire, would you like to answer that? Do you feel comfortable answering?
Yeah, that's absolutely fine. So I think it depends on a number of things, really. So I would say if someone has lower leg edema and they don't have multiple venous signs, you're not seeing that they've got lots of varicose veins, they're quite early on in their journey, you may want to start with a below knee garment if they haven't got any fluid sitting above the knee. If that patient right from the get-go is happy to wear above knee, I would say absolutely go for it, because of course it's going to aid that fluid. The thing with using below knee garments is that then when things progress, you can get that fluid sitting above the knee. But it's one of those things where you need to speak with your patient as well and see what they would be comfortable with. Because I think if the patient has that knowledge of, I can start in this place, but it may get worse, or I've got these symptoms, these varicose veins, which shows I may have some insufficiency going on in my thigh as well. If they are on board with that and it's a plan that they are happy with, then they're going to be a lot more likely to comply. So it's just about giving them all of that information for them to make an informed decision and knowing the risks.
It's about your patient assessment. If the patient has a problem above the knee, then we need to be looking above the knee and assessing that, and assessing if they need thigh length or tights, if they need further compression. And how do you feel about the pulmonary edema? I don't know if you just wanted to refer to the best practice guidelines on that, Claire, because there's 2 best practice guidelines in the UK, and Professor Rabe, I think he's left the call, but he was involved with some of the studies around patients with heart failure and compression. Are you happy to
dip in on it a little bit?
Yeah.
So I would start off by saying that just seeing heart failure diagnosis on someone's notes is not enough to then turn around and say, absolutely, they can't have compression, but there's other things that need to be looked at. So it's looking at the level of edema that's in the legs. It's looking at their symptoms. How short of breath do they get? Have they got edema? Do an assessment. Have they got edema sitting at the top of their thighs? Have they got edema sitting in their abdomen, in their back? What's their risk factor? If they've got edema just sitting below the knee and they're not getting short of breath on exertion, they're able to lay down, and their ejection fraction is good, maybe use some light compression to help to move that fluid. If you want to take caution, do one leg at a time. And then just with every time you're changing, or every time you're seeing that patient, just assess where that fluid is moving to make sure that it's not getting higher and higher.
Right. Yeah. So absolutely, it's not a no, is it, for these patients with heart failure? It's about that individual patient assessment. And there are guidelines out there now to support clinicians with that. So I urge anyone watching today to have a look at those guidelines. Thank you for answering those. I know it's always, putting you on the spot when questions come in, but we do love questions. So, please feel free to ask any more. So with that, I really wanted to thank you, Claire, so much for that. So we've seen, what should be done and about prevention, and we see what it's like in a real world situation, what Claire and the nurses are dealing with out there. In the UK, the nurses do deal with edema. Now,